Well, welcome everyone to our community town hall. And this is a series to share ideas about the health, prevention, and treatments that impact our community. I'm excited to be moderating this discussion today. My name is Bené Watkins Chambers, and I am the president and CEO of Crossroads Community Services here in Dallas, Texas. Today, we will have panelists from the University of Texas, Southwestern Medical Center, and we're going to be covering a number of topics, and we have a couple of slides that we need to show you as we're starting off today. And these are basically a few of the housekeeping things that we need to make you aware of. And so I am assuming that you can see the slides. Can I get a thumbs up on that? Am I supposed to be sharing them? That might have been the case. Let me do that while we still have some folks joining us. Apologize, friends. All right. Um, let's pop these up here. Okay, so the first slide you should be seeing is the announcements and the disclosures. So if I can get a thumbs up from my panelists that you can in fact see those slides. This is just to make sure that you are aware of the financial relationships of our event speakers and our administration. These next two slides, though, are the most important. Many of you are here to get your CME credits today, and so we want to make sure you know how to do that. We're also going to drop these instructions into the chat. And so for those of you who are faculty and staff of UT Southwestern, you're going to want to text YEKDOW to the number that you are seeing on your screen. Or you can also go to the link that you're seeing. And again, we're going to drop this into the chat. For those of you who are not, and just a reminder, this is for today only. So it's really important that if you're looking for these CMEs, that you are doing this today. And you're going to receive a confirming message as it relates to whether or not you've actually registered properly. And for those who are non-UT Southwestern participants, you should be getting this information in about a week via email from the CME office of UT Southwestern, Mr. Mark, and I'm not going to mess up his last name, but you should be getting that in the next week. If you do not, definitely reach out in this email to let us know. So with that, I will stop sharing so that we can jump right into our panelists today. So today's town hall, as many of you are aware, is focused on a discussion about community academic partnerships. We are talking about how we take those partnerships beyond their initial engagement to foster ongoing relationships. The Community Assistance Research Partnership in Dallas, Texas is one of these examples, and we have one of the members, one of the leaders and founders of that with us today, Dr. Tammy Leonard. You're also going to hear from some of our principal investigators on ongoing projects from diverse sectors and disciplines, including developing nutrition interventions for people experiencing food insecurity from Dr. Hollis Hansen, culinary medicine, which is a topic we're hearing a lot about today. You're going to hear from Dr. Jacqueline Elbin and Millette Seiler, and then new food and financial coaching models that we're actually piloting here at Crossroads. You're going to hear about that from Dr. Tammy Leonard. And so when we think about Crossroads, this is my chance to throw in a little plug for us. Crossroads Community Services has been serving the Dallas community, those who are affected with food insecurity, for about 22 years. Our mission is focused on using a collaborative approach to truly revolutionize the pantry distribution model. We do that with food equity research, which you will hear a little bit about today, with client-centered services, and really being a collaborative partner. So as we jump into our first presentations today, here's how you can be engaged. You're going to see a button there with Q&A at the bottom, and you can enter your questions there. And after all of our presentations are done, we will actually have an opportunity for our panelists to begin answering some of those questions. If you have something specific for a specific one of our panelists, please feel free to address them in the chat, and on those, they will address you directly. So as we get started off, we're going to start off with Dr. Kelsiana Hollis Hansen, and she will be presenting the first segment on interventions aimed at improving food insecurity and diet for people experiencing food insecurity. Dr. Hollis Hansen, thank you for being here today, and we look forward to hearing this presentation from you.
Thank you so much. Are you all able to see my screen? You have a thumbs up? Wonderful. Okay, so you have an introduction of me, and I just want to very briefly give an introduction of my team and say thank you to them, especially Carolyn Haskins, our program coordinator, and Jessica Tercios, our senior research assistant. And also to Crossroads, as they offer us a really unique opportunity to have our research team actually housed on site at their pantry. And so Jessica and Carolyn actually work at Crossroads every day alongside their staff and their shoppers. So thank you. So interventions and programs aimed at improving food security and diet quality through the charitable food system have traditionally focused on these 4 areas, according to 3 systematic reviews. Social and medical referrals, which are recommendations and connections, usually through a pantry navigator. Once a client is eligible for one of these programs, they help them to enroll or re-enroll and receive that assistance. You can receive nutrition education either through a SNAP Ed program or the pantry's own programming delivered through community health workers or a dietitian. And then there are behavioral economic strategies like nudges and taste tests, which prompt clients to make healthier purchases. However, people that use food pantries are facing several challenges. We don't have time to go through all of them today, but 2 that I want to highlight are a severe lack of time. So we know most people that use a pantry have at least 1 job, if not 2. And they're also caretakers, especially at Crossroads, who have a number of multi-generational households. So we have caretakers of both children and older adults. And so there's a real lack of time available for preparing healthier foods. And then there are also some physical constraints. So either physical disabilities that make it challenging to physically prepare meals, or a lack of physical space in the home for preparing meals. So we wanted to test 2 strategies that may address those barriers in particular. And we also wanted to learn more about what nutrition interventions are most preferred by Crossroads clients themselves. So we conducted the pantry preferences studies in the spring of 2023. One was a cross-sectional survey on clients' needs and preferences for different nutrition interventions. And the other was a pilot randomized control trial where we randomized people into 2 groups, 70 clients. So 35 people received no prep heat and eat meals, and 35 people received meal kits. This was an additional to the typical food that they received from Crossroads Pantry. They received 84 meal kits or no prep meals, which was enough for each person and 2 additional members of their family to have 2 meals per day for 14 days. And participants were able to select from a menu of 14 breakfast items and 14 dinners. These pictures up here on the top are an example of a no prep heat and eat meal. So these are meals that you can put in your microwave or your oven, depending on your preference, and heat them up right away and eat them. They are the meals we use were provided by a medically tailored meal distributor. We didn't call them that because we didn't have a physician prescribing them, but they were generally more nutritious meals. They had, a good amount of fruits and vegetables, lean proteins. They were a little bit lower calorie, lower sodium, and lower sugar than a regular prepared meal. And then our meal kit, there's an example here on the bottom, was where we bundled ingredients with a healthier recipe that would instruct how to make those meals. Our meal kits were matched in quantity and content as closely as possible to our no prep meals. And we also aim to replicate the no prep meals standard weight of meat and grains as closely as possible when creating our recipes and selecting ingredients. Ingredients in our meal kits, I'm heading off a question that I get a lot, but they had a mix of perishable items like fresh carrots, cheese, and whole wheat bread, semi-perishable items like potatoes and pre-cooked chicken, and then also non-perishable items like brown rice, low sodium black beans, and frozen produce items. We did hypothesize that no prep heat and eat meals would be more effective than meal kits, just because, again, they more directly address some of those barriers of time and physical constraints. And I will share with you shortly what we found. And then just really quickly, our study population. So the demographics of our study population were generally reflective of Crossroads clients as a whole. So about 31% identified as African American or Black, and 63% identified as Hispanic or Latino or Latina. About 90% were women. 43% completed the study in Spanish as it was their first or preferred language. And one thing I want to highlight really quickly is that about 47% indicated that they did not have medical insurance within the past 2 years. This includes not having access to like Medicare or Medicaid. And 47% indicated that they did not seek medical care when needed within the past 2 years due to concerns around cost. And although this isn't directly related to what I'm presenting on today, I just want to remind us all about this when we're thinking about appropriate nutrition and health promotion programs for this community, and also what programs we might be able to implement to get people who are uninsured and underinsured access to no or low cost insurance programs or health plans. And what we actually found. So our two main outcomes of interest that I'm presenting on here today are perceived diet quality and food security. And so perceived diet quality is a one-item measure, and it asks clients to rate the quality of their diet on a scale from 1 to 5, 1 being poor and 5 being excellent. It is actually a very helpful measure in this setting when you're conducting community-based research, because it's quick and it's easy, and it has actually been shown to correlate with objectively measured health outcomes like BMI and cardiometabolic indicators. It sometimes actually correlates better than food frequency questionnaires because there's a lot of under and over reporting about how much people eat. So you can see here at baseline, a majority of clients indicated their diet was fair or good. And at follow-up, a majority indicated their diet was good or very good. So what we found was that on average, participants in both groups, our dark blue line here, that is a solid blue line, is our meal kit group, and our no prep group is this orange dotted line here. So we found that participants that received meal kits and participants that received no prep meals both had improvements in perceived diet quality over the study period, but we did not find evidence to support our hypothesis that no prep meals were better. So both groups were equally good. And then in our changes in food security, our scale is going in the opposite direction here. So a lower number, a 0 or a 1, actually indicates that an individual is more food secure. So we found that in both groups, people went from having low food security and still, we're on the borderline here, but getting closer to being food secure at the end of our study. And this was not actually a significant difference, even though our confidence interval bars here don't overlap, likely because of where we started at the beginning. However, I do think that over time, if we would continue, if these same trends were to continue, we would actually see that meal kits were increasing perceived food security more than no prep meals. And then very briefly on our questionnaire findings, the demographics were nearly identical to our RCT, and just because I have limited time, I'm not going to go into all of it, but just to very quickly mention that our African American or Black population participated a little bit more in our questionnaire survey, so about 41% there. And then we had slightly more participation among men in the survey at 16%. The nutrition intervention preferences questionnaire was developed by Kristen Cooksey Stowers at the University of Connecticut and asks clients to rate their preferences for different nutrition interventions on a scale from 0 to 4, with 0 being don't like and 4 being like very much. Those scores are then summed for a nutrition intervention. I'm trying to speed up here. Nutrition intervention index from 0 to 56 on the traditional scale. On our scale, it was 0 to 60 because we added that extra item on no prep, ready to eat meals. So what you can see here in our findings is that generally across all participants, the mean was about 49. So clients do find nutrition interventions generally very favorable. And the 3 interventions that received the most support were bringing more healthy items into the pantry, meal kits, and making healthy foods more noticeable on shelves. The 3 interventions that received the least interest or support were a smartphone application that would allow clients to scan an item and read the nutrition information, the no prep ready to eat meals, and restricting unhealthy donations. I do want to mention, though, again, that this is a scale from 0 to 4. So a 3 on the scale is not necessarily unfavorable. It's still closer to favorable than unfavorable. The only thing that seemed to be unpopular with a larger number of clients was the restricting of unhealthy donations. And anecdotally, we heard feedback in research appointments that clients with diabetes might need a piece of candy if their blood sugar gets low. And about 30% of our participants self-reported a diagnosis of prediabetes or diabetes during our eligibility screening. So while not conclusive, again, that's just anecdotal. It was interesting insight for us to have in thinking about how we respond to these types of concerns and what interventions clients themselves actually want and why or why not. So just in conclusion, nutritious meal kits and no prep meals may be desirable nutrition intervention strategies for people that use Crossroads Market and may increase food security and perceived diet quality in the short term. Counter to our hypothesis, meal kits are actually looking like the more popular and more promising intervention. Again, I'm super limited on time, but one of the reasons we speculate that might be is because our population indicated they cook at home a lot. And so they tended to just like the meal kits a little bit more. Our findings are limited, obviously, by a small sample and a very short follow-up period. It was only 2 weeks long. It was a pilot study. So our future studies will continue to test both interventions and possibly as a part of 2 components to 1 intervention, because one of the things we heard was like no prep meals might be great for sending off with your spouse for lunch or having a quick burrito for breakfast, whereas meal kits are more appropriate for like dinner for the whole family. And then we'll also include a group that only receives extra pantry provisions, as a limitation is that it could just be having had this extra food is really what was driving improvements in diet quality and food security. So we will include longer follow-up, objective measures of diet quality, and relevant clinical outcomes in future studies. Thank you so much for your time.
Thank you, Kelsiana. Now we will hear from Dr. Jacqueline Albin and Millette Seiler.
Hello, everyone. Again, I'm looking for that thumbs up. Can you see my screen? That's funny how
it is there, but not in presentation mode yet.
Let's see. I'm doing a dual screen, so it might.
We thought that after the pandemic started, we would eventually be super confident at sharing slides on Zoom, but here we are.
Do we have it now?
Yes.
Okay, great. I have 2 screens, and so apparently I have to unshare and reshare. So, all right. Well, hello, everyone. Dr. Albin and myself are going to be co-presenting, and we want to tell you a bit about how we integrate Teaching Kitchen, our culinary medicine initiatives, into our clinical care through a community-centered lens. So you can see our credentials up at the front. We both have a clinical practice here at UT Southwestern, and my home base also happens to be within Moncrief Cancer Institute, which is the nonprofit arm of UT Southwestern Harold C. Simmons Cancer Center. All right. So we would like, again, to just introduce our team, talk a bit about what our program is like, and share a few lessons learned along the way. We really like to flex that we are a physician dietitian co-led team. And where that originated from, one of the sayings we say quite frequently with any teaching kitchen program is, if you've seen one teaching kitchen program, you've seen one teaching kitchen program. And we started with the resources that we had at the time, which was a dual board certified physician with a passion for education and food focused leadership, and a registered dietitian with some ad hoc culinary education. And that was the beginning of our teaching kitchen program at UT Southwestern. We have divided our teaching kitchen mission into 3 buckets. One being a hands-on kitchen education for our learners. We work with a variety of learners, from med students to our family medicine residency program, to other professional learners at University of Texas Southwestern. We also, you've heard a bit from our colleague, Dr. Hollis Hansen, about some of our translational and behavioral research that we advocate for. You can see how teaching kitchens really we're hoping you see a bit of this is just one small slice that fits in with food as medicine and other social determinants of health driven conversations. So that's a big part of our practice. And then a little later on, I'll turn it over to Dr. Albin, and she will share how we are implementing teaching kitchen concepts into the clinical care model and integrating that into a reimbursable model. So we have here in the Dallas-Fort Worth area, and I know we have a large population of our listeners from UT Southwestern in the Dallas-Fort Worth area. But for those that may be outside of the area, it is a huge urban center, but also we have a lot of rural counties that we serve. So the Dallas-Fort Worth area and Fort Worth and Dallas are about 30-minute drive from each other, just to give you a reference what that looks like. So I have a teaching kitchen education center that I have in Fort Worth. We have our clinical nutrition lab that is, we share that space very gratefully with the nutrition program at the university over in Dallas. And then we will tell you a little bit about some great initiatives that we have coming up in the southern sector of Dallas at Redbird. But we also do a lot of community outreach when it comes, we call it pop-up kitchens and demonstrations at clinics and food pantries and community centers and churches. And we have a lot of innovation there. You can see all of those. Just a quick snapshot of what this looks like in our education center. You can see, we like to tell people that we don't have a big shiny kitchen, that teaching kitchen innovation can happen at any level. You start with what you have, whether that's a blender on a 6-foot table or not. So this is some foundation funded programming that we do for cancer survivors. Anyone with a cancer diagnosis is eligible to take part in this education over in Fort Worth. And then this is a picture of what the clinical food lab looks like over at the School of Health Professions at UT Southwestern. You can see it in all of its home economics glory, but we actually celebrate that because it really simulates what our learners have in their own homes. We're not trying to, make it glamorous. We're trying to affect change for kitchen simulator units, and we can accommodate up to 24 students. I'm going to turn it over to Dr. Albin, who's going to share with you some of our research in the community.
So I would love if you can actually just go back a moment, Millette. I want to say that perhaps the 2 most powerful and enjoyable aspects of the work that we do are the combination of our learners and our community partners. And it's our learners that actually originally drove us into the community, because those of us on faculty tend to get in our silos of what we do every day in our health systems, and we forget to learn about the amazing work that's already happening in the community and how we can elevate the work that we each do when we partner together. And so on the next slide is actually our original project that brought the teaching kitchen team into the existing care partnership that had already been developed by Dr. Tammy Leonard, Dr. Sandy Pruitt, and others at Crossroads. And we really had the opportunity to build out what does it look like to take basic food preparation concepts and utilize our students as a resource in the community. And so this project, which was started pre-pandemic and ran during 2018 and 2019, was just what Dr. Hollis Hansen presented to you. What are the key ways that people bring resources around food to food pantry populations? It's taste tests, it's nutrition education, and kind of bringing those together in a way that's accessible. So we had teams of students that would develop recipes, particularly around what was seasonal, what we knew was going to be available at those pantry sites, and using the nudge process as well. Certain ingredients that we wanted to highlight, such as legumes, how do we show people ideas for how they can incorporate those into their dietary pattern? So we had recipes that were designed mostly by our students and then approved by Millette. And then the students would prep food samples and handouts and talking points that were in English and Spanish. And they would have stations at food pantry distribution days where clients and their family members would come and engage, ask questions, take recipes. And this was really well received. Like the rest of the world, when the world shut down for the pandemic, we halted this for a long time. But over the past year, we have restarted this, particularly at the home base of Crossroads. This original project was at satellite sites. But throughout this resuscitation, we've been able to add unique layers of making what we offer better by gathering client preference feedback on different recipes and types of foods. So the intersection of taste tests and things that seem like really simple interventions can be data-driven and then can drive future interventions and ensure that they're culturally sensitive. And I'll come back to that. So we want to highlight that Crossroads is distributing an incredibly large amount of food. And when we're giving food, we are addressing access and food insecurity at the most basic level. But once it's paired with the layers of nutrition education that helps people know, how do I take this to my home and make something that my kids are going to actually eat? Or sometimes in pantries where client choice is not prioritized the way it is at Crossroads, families aren't always sure what to do with certain foods. They need guidance and support if something feels unfamiliar and they want to try something new. And then how we layer that on connection to healthcare and also connection to ensuring equity in all of our different communities, not just the ones that have great resources, is part of what we're also passionate about doing together. So on the next slide, you'll see how Millette and I as clinicians said, what can we do to bring this back to the clinical environment? And we're really passionate about this because these efforts require funding, but when you can connect some of the work back to the clinical environment, it then can be incorporated into existing funding structures for clinical care. So the first thing that we decided to build was an e-consult, which is an existing model within healthcare systems where expertise can be sought, and it's a written guidance tool. So if someone requests an e-consult in culinary medicine, they would receive input from us as experts. And this has been a way for, my alarm went off that told me we need to wrap up soon. Okay. The tool that we're able to provide back to the consultants includes resources for patients that take them back to the community. Because one of the biggest challenges PCPs in particular have is they don't have a lot of time to look up resources for patients with food insecurity. So we try to help people identify existing partnerships where they already live when we know that they need food security support and nutrition education support. So then taking this out of the electronic medical record into more of a one-on-one patient interaction, we built out a one-on-one model where patients can come see both of us. And it is at our Redbird UT Southwestern Clinic. And we provide really personalized feedback and guidance for them on how to make dietary changes. And the main take home here is that everyone is an individual. And when we're designing food-based interventions for populations, we have to realize that the individual piece of it is still vital, because each person has a relationship with food, cultural preferences, and a history of maybe some negative interactions in the health system that we have to overcome to be able to help them make some of the dietary changes that we hope will improve their health. And so pairing with trusted community partners is how we do this best. And then lastly, as we think about moving forward, we believe that there is an enormous opportunity for health interventions around teaching kitchens, food access, nutrition education to be community co-led. And this allows us to bring education in, not just at the hospital or at the clinic visit, but in a community setting where you not only have the place that's closer to home and the place where you feel known and seen as an individual, but you also have leadership from each individual community, bringing it back to the key items that bring in cultural relevance, what's locally available, and they know the populations that they've been serving. And so we've been really inspired by building out community co-leadership in group cooking classes as a patient care strategy. And that's what we'll be launching next in partnership with Crossroads and a couple of other community organizations in Dallas. And we always like to remind everyone that when you're defining new and better ways to do these things, it can feel lonely, and partnering with the community has been what has kept us going through building new models. And so I encourage everyone who's looking to innovate in their own space to think about getting outside of your traditional walls and finding new partners. And I will turn it back over to Benet.
Awesome. Well, thank you both so much for that presentation. And we will move forward to Dr. Tammy Leonard. And then after that, begin the Q&A. Thank you. Dr. Leonard, it looks like we lost your video there. Tammy? Uh-oh. Technical difficulties. While that's happening, and I'm sure she's reconnecting or figuring that out, I will just talk briefly about what these partnerships have meant for Crossroads and what Crossroads has continuously continued in this space, working in these partnerships. And so we are at this point really understanding that this is the foundation upon which we were built. Our founder began understanding that in order to really create solutions around this issue of food insecurity, that we were going to actually have to be really creative and innovative, but most importantly, be willing to be nimble. So as you're thinking about how these partnerships might work with other organizations, and for other organizations who are on this call today, it is really about having a spirit of innovation and creativity. So at the end of the day, you know, we could decide this was really hard, and sometimes it's not always the most convenient thing, but at the same time, we're always looking at what the outcome is for our client, our shopper, and our community. So we're always looking at how do we actually make this work? How do we partner with these physicians who are coming into our space, with the researchers and investigators who are coming into our space, and really coming to agreement that this is what's best for the people that we're serving. And so I'm often asked, you know, well, does this get complicated? Do you have issues with it, with shoppers sometimes who may not want to participate in these things? And the answer is yes and no. It can get complicated, but ultimately, it is really about making sure that the work that we're doing is for the good of the people that we're serving. And so I know that Dr. Leonard is trying to get back in. There she is. Hi.
Recording in progress.
We see you there.
Great. Sorry, guys. My Zoom app on my computer just exploded. I don't know why. But Kelsiana and Jacqueline, I emailed my slides to both of you just now. Could one of you perhaps share a screen?
I haven't received it yet, but I don't know if you have, Jacqueline.
I'm keeping an eye out.
It might be going now. Sorry, guys. I've never had Zoom just do what it just did.
Technology, I do believe, has a mind of its own. So until we do get the slides, I think you can go ahead and get started. I was telling them about our role in all of this. So
wonderful. No, thank you, Benet. So when the slides get pulled up, you'll see a picture. But the point I wanted to make with that picture was just describing the situation that many low-income households often find themselves in, and that is oscillating between states where they're challenged, but in one situation they're challenged, but they have an overall stable environment in which they're in. And in another situation, they're challenged, but they're in crisis. Within that, there is financial coaching. Financial coaching works pretty well. It's evidence-based, and it's been very effective at helping households that are in the challenged but stable state to pursue goals that move them closer towards financial security. But what we don't have a good handle on is a program that can help when people are in the challenged but crisis state. Generally, what we do when people are in that challenged but crisis state is try to provide resources to take them out of the crisis state and put them into, send them back towards that challenged but stable condition. But what we have tried to innovate around is taking the strength of financial coaching and creating a similar model that can help in that challenged but crisis state, that can build resiliency in how to handle crisis. And we call that resource coaching. And of course, there's different types of resource coachings that may be available, but food resource coaching is the type of coaching we focused on first. And one of the reasons we've done that is through realization that people in crisis generally have very little bandwidth for changing the things that need to be changed to prevent a future crisis. But if we are preventing food insecurity at a food pantry so that we can establish a routine relationship with them, we can bring individuals a couple steps away from the crisis and have an opportunity to intervene with some coaching models. And so the big questions we are trying to ask is, can the coaching philosophy be integrated into the pantry appointment to help with food resource budgeting? And furthermore, might people using a pantry to prevent food insecurity have interest and bandwidth to engage in financial coaching? And so as we ask these questions, we've developed a 4-step model that's really that food resource coaching box of the figure that I don't think you got to see, but that's okay. So within each step of this process, we've inserted tools that kind of build and layer upon each other. But while we've designed it logically as a linear process, we conceive it in reality being used as sort of an all-you-can-eat buffet. And that is the fact that we understand that individuals are going to come and present with different needs in different situations. And so they might enter at different steps, they may go forward, they may go backwards. So it's sort of an all-you-can-eat buffet approach. And so within these different steps, we've tried, Kelsiana, you can kill the slides. I've changed them up since those old ones. Sorry about that. But within these different steps, we've tried to embed 2 key concepts, and one is relationship building and the other is reflection. And this is really how we have lifted what we've decided we're lifting from the financial coaching philosophy. And that is that coaches are accountability partners. So the relationship is key, and coaching is driven by clients. And so we want to help infuse tools and opportunities for reflection to occur so that clients can be more capable drivers of their coaching experience to build internal resiliency through getting through crisis situations such as food insecurity. All right, that's all I'm going to say about food resource coaching, although we can deal with it more in the Q&A and as we have discussion. But I just want to end with a brief thought now that we've heard from some really great projects that are being done within the CARE Community Academic Partnership. Just talk briefly about how it was begun and developed. CARE was designed as a community academic partnership with our aim being to improve the lives of low-income populations in our area. And we thought this should be done through interdisciplinary, multi-institution, community-based collaboration. I think this is relatively unique, not the idea, but the fact that we have a community academic partnership that was built around a singular focus of collaboration. Usually community academic partnerships spring up in an effort to solve a particular problem or to initiate a particular program. And they always have the goal, as our goal is to leave a trail, leave a bridge for others to follow, to build infrastructure that will support other projects. But oftentimes that infrastructure that we are able to leave behind is kind of fraught and not so stable, such that people may not want to follow behind us because it looks like a treacherous climb. One of the things we've done with CARE is try to be really intentional from the onset that one of our goals, our top goal, is to build the infrastructure. And then projects can be built on that infrastructure that can achieve a variety of aims. And so CARE, we've titled it a community academic partnership. That's the words that are out there that describe this sort of relationship that we have. But I think really it can be better described as a community innovation incubator. Our goal is to facilitate innovation to improve lives. And I think one of the things that we've learned by doing over this past 10 years to do that, just a few points. One is to build an infrastructure, not a program. It's really hard. Funding rarely comes to build infrastructure. It always comes to build programs. And so, but you can be crafty in that. As long as you understand how important the infrastructure is, we've found it's easy then to justify within your goals of your project to leave behind slight improvements to that infrastructure over time. And as long as everybody stays focused on that. And we also try to encourage partnership that allows for autonomy. You just heard some amazing work that Dr. Hollis Hansen and Dr. Albin and Millette Seiler are all doing. Those are projects that I never envisioned at the outset of CARE. I have really limited involvement in, but they're hugely vital to the success of CARE. And so I think it's important that when you think about developing these types of community academic partnerships, you're really intentional about guarding the incubator, but not your particular solution that you might be pursuing within that incubator. And then the greatest joy, of course, is identifying shared resources, philosophy, ideas, and needs that can be shared among all the participants of the incubator and really hold those up so that newcomers understand the value that they're walking into. A great phrase that a colleague has shared with me that I just love is that we excavate the good and we share the good. And a lot of times we talk about the highlight to doing community work and how rewarding it is, which is absolutely true. But there are hard days and it can be a challenging process. One of the roles of a community academic partnership, I believe, is to really do that service of excavating the good and all those difficulties you might encounter and making sure you amplify that and share it. So with that, without my slides, I apologize again for the technical difficulties, but let me turn it back over to Bené.
Perfect. Well, you did great. That comes from just really being a strong partner in this work and really understanding the fundamental of how we got started, and then why this continues to matter for all of us to really, I like what you have reframed this as, is to be an incubator for innovation. Most recently I was having a conversation with a major funder who said, I was looking back over the last 10 years and we have been funding food insecurity initiatives for 10 years. When are we ever going to get to a place where we are feeling like we're making headway? And I said, well, it requires more than just funding food initiatives. There's a different level of investment that's required. And I think that is what these partnerships and these collaborative efforts are showing, that it's not just one single solution. It's not one single pathway to answering the question, and it's going to work differently in different communities based on who's participating and why. So I think that what we're hopefully sharing with folks today is that this works well here. When you try it or partner with any one of these groups in a different community, there are going to be different aspects that have to be considered. But in all of that, it has to be a willingness to push through the barriers. And so, because there are many, and being creative in even how you do that. And again, as I mentioned earlier, staying focused on the end result, and that is ensuring the best service possible to the people coming to us for service. So moving into our Q&A, we've got about 15 minutes and we've already got some questions in here. I want to start out with a question of what are the first steps you would suggest for creating a teaching community kitchen? And I think Dr. Albin, this was one that you wanted to reach out and answer.
Sure, and Millette will also probably have some insights. I think it's really vital, and this is where the community partnership can be a guide. It's really vital to ensure that we don't start programs just to start programs. And I think with teaching kitchens, we all know everyone eats, and everyone who prepares more food at home is going to likely have better diet quality than when eating out. And it also can typically lead to cost savings. So in general, preparing more food at home is a win. And we want to give people the skills to do that within their various constraints and barriers. However, starting a teaching kitchen program without really understanding, just as Bené was speaking to, who you're serving, that's a huge challenge because here in Dallas, the cultural diversity is immense. And we have to think about, are we working with a population that is homogenous? Is this a population of refugees where all of the food we have in this area is unfamiliar to them and they've never even heard of that spice? Are we working with a population that loves to cook, that doesn't love to cook? And so I think that it starts again with, if you want to start a program, taking inventory of who you want to serve and why, and then using community partners to infuse expertise about that population. And then allowing this iterative co-design process, not being attached to doing it a particular way. We actually wanted to move forward with classes at several different points where we actually backed up to doing demos because people are finding a way to get to their food pantry pickups, but an additional weekend class was hard for people to get to. So in the past, when we piloted food pantry based cooking classes, there was extremely variable attendance. And as a national community, we're all trying to figure out how you overcome people's barriers to one of the other questions. And I'll turn over the more specifics of that back to Bené, but I do want to say you cannot isolate any social vulnerability. So food insecurity does not exist in silo of, not thinking about transportation and childcare and all the many other things that weave into someone's ability to access the resources that are even in their community nearby. And so I think as we continue to build these programs, all of that has to be considered. So thank you to Ms. Coleman for bringing that up. And I think that that's, it's just an iterative process of that didn't work, let's try something else. And knowing that each community is going to be different in what works best.
Yeah, thank you for leading into that next question to Jacqueline. The question that is next on our list here is, one of the biggest barriers that I think most of us would say that our clients experience is transportation. How do we get them to the services and to the programs? And that is a barrier here as well. And so we have struggled with creating volunteer opportunities where volunteers are taking food to folks, but really it's how do you get them here when they do for a teaching class need to be present. And I think too, there is creating opportunity. Can they participate as much as they can virtually? I know we don't like that. It's not a touch, it's not a feel, but at the same time, I get to be present and I get to visually see what's happening. And where you can do that. Are there services like PAN, as mentioned by Ms. Coleman, that are available to provide transportation? DART has some special services. And will your clients qualify? Those are all the things that as you're thinking about launching a program, as Dr. Albin said, you got to figure that out first. How are people already getting to you? What are already those challenges and barriers? And then what are those services and the qualifications, and seeing if they're going to fit your client? And if not, do you have a breadth of volunteers that would be willing to help you in some way. And then again, adding that virtual piece. But to answer your question, we right now don't have, the question is, how are we using a transportation service to get our seniors here for Senior Thursday? We have Senior Thursday shopping just for them. And the answer is no. They either are driving themselves or they have a family member bringing them, because we don't necessarily fit into a route. And so but we already knew that. And so we knew how to structure that. It was also mentioned in the chat that infrastructure is key. Do a good evaluation of your existing programming and infrastructure, in any case before you add something else, but in particular, these offerings that will most likely be very interesting to the clients that you serve. So the other is, how do you measure the impact that food pantries and other initiatives are having on the community? I will open that up for you all for one of our panelists to answer.
Well, I'll start being the token evaluator on the team here. It's tough. It really is, because you want to capture all the impact, and the impact is going to be multifaceted. It's going to be different for different households. Oftentimes, insecurities, they don't come in isolation. So if you're experiencing food insecurity, you've made some decisions about your finances, and you're either cutting it close or barely making it somewhere else as well, right? And so the way a food pantry's resources may help one family, it might mean that they kept the lights on at their house. In another family, it might mean that they were able to, have the kids do better in school because they had food. It's going to have a multifaceted impacts, and those impacts are going to differ by different households depending upon what they've decided to cut back on to alleviate others' insecurities that they're in their lives. So how do you evaluate in that context? I think this is where, as somebody who does quantitative evaluation as my bread and butter, that's not enough. We can't just measure, say we're going to measure these few outcomes and do a survey and say this is going to be the impact. The impact is multidimensional. People are multidimensional. We've got to take an approach. And I always advocate for different signs of listening to our impacts, right? So you can collect data. You can think about the bigger ways, and I would say that data should be centered around trade-offs that people face. It can also be some of the quantifiable ways, kids' performance in schools, right? But you also have to listen to people and let their stories inform how you understand the impact, because it's through those stories and the individuals that you'll see truly the context around the impact that the pantry is making. You can do that systematically, right? We do this. We don't do it well enough. We should be doing lots of interviews. We should be talking to lots of people so that we can start to distill the patterns of how these impacts are taking root. And my guess, to Bené's earlier point, they're going to differ across communities, across different groups of people. And a lot of times we like to make assumptions about the patterning. And I just don't think as a field, we have adequate amounts of data to really understand the patterning of the impacts. And so we have to start there by listening and then form our further measurements from that.
Thank you, Dr. Leonard, for that. The communities will tell you it's either working or it's not working. And I think that leads into the next question from Ms. Coleman as well is, there's been some work in some communities about bringing more awareness to farmers market, making farmers markets available in communities that have teaching or food tastings. The team at UT is doing that here in our intake area. And you're right, it makes a difference in what people would decide to take or not take, eat or not eat. And the question is, how do we bring more of those opportunities where the food is there and some of the tasting opportunities of how I might prepare this food is also there, and especially in areas of the food deserts. So Kelsiana wanted to take a run at this one because I know your whole study is about this very question.
Well, the next one on building infrastructure, but just to wrap up on how we can expand it, I do want to mention that the North Texas Food Bank actually has a healthy pantry nudges program too, that pantries in the North Texas area that can participate in. But then on the next question, that is on some examples of infrastructure changes that we can help facilitate as researchers. One of the things we haven't, touched on as much is, like money and grant funding. And so one of the things that I try to do in all of my projects is fund people who will actually carry out some of the more challenging parts of the research, and then also funding people at Crossroads as well to help support. So we budget in both Crossroads staff and then our own staff. And then not even just applying for our own grants, but Benet and Cynthia, sometimes when I'm applying for grants, Cynthia is Crossroads Vice President of Development. She'll send me a logic model or send me a part of the proposal and say, hey, what do you think about this? And it's kind of this iterative process where we're working together to build programs. And so that might be a program that I'm not involved with at all, right? Like I'm not implementing that program. I'm not necessarily evaluating it. But I am able to provide some of my own research expertise to then provide guidance that can make it more likely for Crossroads to secure their own grant as principal investigators, or that they have ownership of. And so I think that's one of the ways, is not just expecting them to add value to our research projects, but to allow our skills to add value to what they're doing in the community. So that's one of the main ways I see that. I don't know if anyone else wants to answer that question as well.
Thank you, and thank you. Because I think that's also really important, is sometimes as the not-for-profit organization, you don't know how to craft the narrative around what you need to do some of these activities. And the funders are not always clear on how these two things come together to really create the outcome of what you're trying to accomplish as an organization. So if you're going to be working with researchers and you're putting grant funding together, building in those infrastructure pieces are critical as well. And we appreciate that. But it's also going back to what Kelsiana said about North Texas Food Bank, Crossroads is a nudge pantry, which means there are tools that we can be given that come down from Feeding America through all of your local food banks that will have tools for you to actually set this up in your own pantry, or to take out into various communities where you identify need. And so you do have to go through a process, or it's a short training to become a nudge pantry, but it can be very helpful in terms of being able to actually have that additional resource and infrastructure that you don't have to create to be able to share into your community. So we are about 2 minutes out. There are no more questions in the Q&A officially. What I'll do is just ask our panelists, or if there are any final thoughts you want to add. If there is an additional question someone has and wants to pop that in. Oh, look at that. But do clients have food access in the waiting room? I will tell you, at Crossroads, we literally were having this discussion yesterday, because one of our challenges is yesterday, as part of an issue discussion, is we have a number of folks who are showing up and they haven't eaten. They haven't eaten the day before. They have low blood sugar. Their blood pressure is high. They're feeling weak. They've been on an all-night shift and they've come straight here and they're exhausted. We're worried about not just the fact that they haven't eaten, but they're also exhausted and they're going to drive from here. So we are looking at ways to use some of the donated foods that we get to have in our stations when we're doing intake. Being mindful that just leaving it out in the open may encourage folks to just sort of bag dump, and we want to make sure that we are being able to meet all of the needs. So that is actually a discussion we're having on how to put it in the intake process and make it immediately available, healthy snacks for folks who are showing up and need that. So we're right at 1 o'clock.
Food demo day, then there's snacks.
That's a fact. And it's actually really good. They got me to try Brussels sprouts. Everybody on here knows I don't. It was good. I liked it. I'm not going to make it, but it was good. I ate it. And so I do think where you can have those types of partnerships in your pantry, in the waiting areas, and have those snack baskets at your intake areas, it can be extremely helpful for the folks that you're getting served. So we are right at 1 o'clock. I want to thank all of our panelists, Dr. Leonard, Dr. Albin, Millette Seiler, Dr. Hollis Hansen, for being here today and sharing this work. And we appreciate you so much at Crossroads, so much more than I think we ever express and you ever really know, but how you have changed this distribution model to be something that is really a model that others are looking at, we're getting calls about all the time, has been because of the work that we've been able to do with you. And I look forward to how we can all take this model and share it in other communities for the same level of success and impact that we're having. Thank you to all of our participants. And that is all we have for today.
Thank you, everyone.
Thank you.
Thank you.